Well, good morning, everyone. I'm going to speak to you about what we do about the patella. And there is always a battle now between whether we should resurface the patella or not, and there's often bad feeling. And the question is, does the treatment of patella, does it make a difference to anterior knee pain? You can look at all these papers, look at all the meta-analysis, but in fact, it doesn't really make a difference. And so the great thing you know is that whether we resurface or we don't resurface the patella, we still have an issue to deal with anterior knee pain. So it was quite a short lecture. It doesn't really matter what you do to the patella, but we will still have patients with anterior knee pain. And it's how we treat the patellofemoral joint during our knee replacements that dictate anterior knee pain. So the patellofemoral joint is the soul of the knee. It actually tells us what's going on in the knee. And all the things that patients complain about, anterior knee pain, difficulty kneeling, climbing stairs, all relate to the patellofemoral joint. So we must think how we deal with the patellofemoral joint. And so I'd like you to think of it as the third space. Now, we're very familiar with the first and second spaces. That's the extension and flexion gaps. And we know we have to balance the flexion and extension gaps. And what I want you to think about is the third space, how you balance the patellofemoral joint, or the anterior part of the knee. And we're not just talking about the patella bone here. We're talking about the patellofemoral joint, the extensor hood, and the soft tissues of the quads, and the medial and lateral retinaculum. So I want you to think of it as a complete whole, and it's highly innervated soft tissue with variable movement. It's not just about resurfacing the bone, it's how you treat the whole third space. And it's even relevant in anterior slides. So we talk about instability, patellofemoral, or rather tibiofemoral instability, but that manifests itself as anterior knee pain because of the increased pressure on the patellofemoral joint. So we have to understand more about patellofemoral kinematics. And we probably don't know as much as we should about this highly sensitive area of the knee. So we've had to do a lot of learning, and this is the three-dimensional learning we have to do. It's not a simple hinge joint. And so we spent a lot of time doing computer analysis of how the patellofemoral joint moves and making a computational model so we can predict how the extensor hood reacts. And this is an important graphic drawn by the computer, if you like. The patellofemoral joint is actually not the big problem. The big problem is the extensor hood. And if you watch this graphic, you can see how the extensor hood wraps around the front of the trochlea here. And it's this highly innervated soft tissue that we have to manage when we do knee surgery. Conversely, if we look at the surface of the patella, the stresses in the patella are relatively low compared to the extensor hood. That's blue and green. And in all these graphics, red is bad and blue and green are good. And if you look at a non-demanding knee, you can see that in normal flexion, most of the load goes through the patella. And that's not a problem because it's not very well supplied with nervous tissue. But if we go to our higher function knees, we can see that the patella drops into the intercondylar notch, and actually most of the load is on that extensor hood. So when we think about the patellofemoral joint, we have to think about the extensor hood as well, and how we manage that during surgery. Once again, if we go to a computational model, we can show you that actually most of the load is in that extensor hood. And you can look as you go to deep flexion, you can see the extensor hood turning red there with a supraphysiological load. It's not about the bone, it's about the extensor hood. Now that means we have to understand how the patellofemoral moves, and the key aspect is about 30 degrees of flexion. Before 30 degrees of flexion, the patellofemoral groove is relatively flat, and the patella will move quite well from side to side. And the retinacular fibers guide it to the center of the trochlear notch. After about 30 degrees, the patella commits to that trochlear notch and becomes relatively stable. So the patellofemoral joint is a bit schizophrenic. In the first 30 degrees, it's unconstrained and highly mobile. After 30 degrees, it's highly constrained and not mobile at all. So it changes its characteristics. So in normal alignment, we would expect to see the patellofemoral joint move into the trochlear notch and drop down into the intercondylar groove. So remember, in extension, relatively flexible, and the retinacular ligaments will guide it. In flexion, it's highly constrained, and the retinacular fibers are loose because they're not doing anything at all. Now, what I want to tell you is not only does the patellofemoral joint move in different ways in different people, it moves differently every different step the individual takes. So it's highly variable between steps. So if I externally rotate my foot in my first step, you can see that my patellofemoral joint will start on the lateral side, be guided by the medial ligament, and then drop into the intercondylar notch. If in my next step I internally rotate my foot, my patellofemoral joint moves in an entirely different way, starts on the medial side, guided by the lateral retinacular ligament, and will sit in the intercondylar notch. If we have a laterally placed tibial tubercle, of course, it all runs down the lateral side, and that's something we have to deal with surgically. So the trochlea is acting as a funnel, if you like. It's recruiting the patellar joint from wherever it lands and guides it into a central point. Now, if we look at our knee problems, that sometimes we create instability here. Here's a lateral maltracking with the lateral retinaculum and the loose medial retinaculum. We realize that we can't leave the patella in that space. And if you think of epicondylar line there, that's where our trochlea will sit of our total knee. So what we will do is we want to get the patella centrally. We've already done a medial approach, and we do a lateral release. And of course, what we've done now is create patellar instability, because I told you that in the first 30 degrees, it relies on the retinacular ligaments, and we've just cut both of them. So that's why we have to think about this instability. And so oftentimes, knee replacements have deep trochlear notches for patellar stability. Actually, that's not what we want. It's entirely opposite to what we want, because in the first 30 degrees, we need patellar flexibility. So now we understand the trochlear. Look at your knee replacements now and try and understand that we want a low constraint early on in patellar flexion with a high constraint later in flexion. And so that's how we're redesigning our trochlears now. So if you look at our new knees now, our trochlears are much less marked because we've understood that the extensor hood is the soft tissue and we don't want any impingement on that side. And so if you look at our uprated designs now, you want to see that much softer trochlea. So I want you to think about, in your next knee replacement, the first space, the second space, but the third space as well. And how much we take away from that trochlea is really important when we balance the third gap. Thank you very much indeed.